Hello and how are you? My name is Winnie Barawa. Welcome to my lesson on non-invasive procedures for respiratory disorders. So this we are going to explore the procedures and tests that are non-invasive and pertaining to helping us diagnose respiratory diseases, or rather what we call respiratory disorders. So in this class we will explore these particular procedures: clinical history, physical exam, all the way to microscopy. In the previous class, we had introduced this, so I will not dwell much into this. Rather, I will flow directly into what each and all of them is. If you've not watched the previous one, you can check the previous procedure on Introduction to Pulmonary Procedures and Tests. So the first procedure to help you identify clinical symptoms and manifestation or product of pulmonary disorders is basically clinical history. So with this, there is checking of history of symptoms, which could be acute or chronic. Sometimes the symptoms could also be isolated or can be combined with general symptoms. So there are some symptoms that are quite specific and can ideally guide us into identifying that we are dealing with a respiratory disease. And part of this includes dyspnea, abnormal breath sounds, cough, hemoptysis, chest pains, and even the sputum production. So if you are looking or querying respiratory disorders, these are part of the symptoms that can guide us. Dyspnea, that is more of like difficulty in breathing or labored breathing and so on. Then the abnormal breath sounds, which could be in form of bronchitis, wheezes, rales, and so on. There's also cough, and cough could be dry or wet cough. Then you have hemoptysis. This is bleeding. This is bleeding that could be present during sputum or bleeding that generally originate from the nasal openings or can be observed into the excretions that are coming out from the respiratory systems. There's chest pains, which could be pleuritic or localized. Then there's sputum production. So these are various histories that you can look into or symptoms that could guide us as you're taking the history from our client. And the second approach is conducting a physical examination. And the physical examination follows the sequence of inspection, palpation, percussion, and auscultation. So in inspection, there could be specific things that you want to inspect or check on. That is the presence of cyanosis. If there's presence of cyanosis or bluishing of the membranes, such as around the lips or the tongue or the epithelium surrounding our buccal cavity, these are indicators that you could be having a very serious respiratory disease that is combining with cardiovascular conditions. Then you have the breathing patterns. If it is deep, is it regular? Is it shallow? You want to see how the breathing pattern is. Status of finger clubbing, that is, the fingers are not properly aligned or the alignment is altered in such a way that they have curved in, then you can be worried of finger clubbing. Then there are any other chest deformities that are very important for us to know, like kyphosis and scoliosis. Part of this affects the patients and they can lead to development of respiratory disorders. Then you have palpations, that is looking for sites that are a bit affected in form of either tenderness, pain, or even enlargement of the lymph nodes. In percussion, we are looking at the sounds produced when we drum different areas of the chest, and this can produce dullness or it can produce resonance. And in resonance, you can have the normal resonance or you can produce hyper resonance. And the last bit is conducting auscultation, that is identifying different sounds that are produced by the patient as we listen to the chest using a stethoscope. You can have wheezes, crackles, the pleural friction rubs, and so on. If you want more on this, I've done a whole videos including how the sounds sound like and also the different ways to do the palpation techniques. So it's all there. You can review our playlist on respiratory disorders. And the third maneuver or procedure that can be done for identifying respiratory, that is non-invasive, is pulmonary function test, PFTs. So what PFTs do, they focus more on looking at how fast the patient is breathing and how much the patient is able to breathe out. So it can look at issues like lung volume. It will explore on the flow meters, spirometry, and the diffusion capacities. So with this, we have various tests that can be done on our patients, but majority of them, they just check on how fast is the patient breathing and how much is this air being breathed out. So as you can see, for instance, here on the spirometry, we use a machine known as spirometer. Through the guidance of the technician, the patient is guided on how to breathe in and release with their maximum abilities to measure their vital capacities. So let's start with the various tests that are done under PFTs. So we have the first test we call spirometry, which is like the commonest of the PFTs. So spirometry normally is done to measure lung volume changes during the breathing maneuvers. And what happens is it focuses on looking at the forced vital capacities, FVCs, in the forced expiratory volumes in the first second, FEV. So what happens is with the testing of this procedure, we look at the essence, mostly the decrease in these capacities, where we're told if you discover that a patient has reduced forced vital capacity or they have reduced forced expiratory volume, it's an indicator that a patient has problems in their respiratory system and they are struggling with their chest maneuvers. So what happens is the technique with the spirometry, you have to guide the patient first by telling them to completely empty their lungs. And once they've been able to expirate or completely empty these lungs, then they're supposed to take a full inspiration, fully like take it in with their deep breath. Then they expirate this with their maximum energy through the mouthpiece. So this is where our client is. So the client will empty these lungs, then do a fresh breath, fresh deep breath, and then the nose will be clipped and they will be told to force out that breath through the mouthpiece, and the technician will be checking the records on this monitor here. So the monitor will be reading the changes and the different volume changes that are happening on the machine, and then they will interpret that to see if there's a normal FVC or there are changes, or there's a decrease or an increase, and so on. And then they can determine now the status of this client. So there is a result that is printing out here, which is very key for the interpretation and analysis of our patient performance. Then we have the second test that can be done for pulmonary function test, that is the diffusing capacity of carbon monoxide, written as DLCO or DLCO, okay? So DLCO is also known as transfer factor, or rather diffusing capacity of carbon monoxide, is also known as a transfer factor. So what this test does, it helps us to test the ability of the lungs to perform gaseous exchange. And that is how able is the alveolar gas being able to attach to the red blood cells or attach to the hemoglobin. So we use carbon monoxide, we don't use oxygen, reason being carbon monoxide can be used as a surrogate for oxygen. And you don't use a lot of it, please, you need to note that. So the gas that contains carbon monoxide, normally it's combined with oxygen a bit, but it's to help us see how the red blood cells, or rather the hemoglobin, is able to attach or exchange. So what happened is we use this test to measure the partial pressure difference between the inspired and the exhaled carbon monoxide. So any changes in this test will help us reflect whether there's a loss or damage to our gaseous exchange surfaces. For example, in diseases such as emphysema and bronchitis, they tend to show you the different status of our gaseous exchange if you use this test. So a decrease in DLCO simply indicates a damage to our gaseous exchange surfaces. And gaseous exchange surfaces, here we are looking at the alveoli and the alveolar surfaces and the blood supply or the capillaries and how all this exchange process is happening. So a decrease in this indicates loss or damage of our gaseous exchange surfaces. Then we have our fourth way of measuring, which is the radiological or the imaging techniques. So we have the chest X-rays, the computed tomographies, the MRIs, and the ultrasonographies or ultrasounds. So these are other methods that are used, but there are some that are commonly used, which are the ones you're going to focus on, and that is the chest X-ray, the CT scan, and the MRI. We will not discuss more on the ultrasounds. So what happens is with the imaging techniques, we need to understand how the lung feeds differ when we are checking them on these machines. So they produce images of the chest and we look at the field. So there's a field, there's a how the field is supposed to look like if it's not affected, and there's how the field is supposed to look like if it's affected or when you have defects. So let's start with the first one so that we can differentiate how our lung fields should look like where there's an abnormal chest X-ray and where there are normal chest X-ray or where there's variations in all these techniques. So starting with the chest X-ray, number one, we use chest X-ray to show or to evaluate on the normal position of our chest structures. We also use chest X-ray to look at different displacements of the structures and if there are any present of abnormal shadows. So in the chest X-rays, normal pulmonary tissues is normally seen as radiolucent and it appears black on the film. So if you look at this film here, these black areas indicates that these are areas that are a bit normal and that they are not affected by anything. But again, areas that are a bit whitish or they're lighter in terms of appearance, they're normally described to be having, affected or they have been tampered, and therefore you can talk about presence of foreign materials like tumors, foreign bodies, infiltrates, or defects generally. So if there are any defects, then you will see the presence of lighter or whiter images. So for instance, in these areas with whitish presence, we will see later on the differences. For example, if you compare figure B and figure D, there's a variation in even the size and how the whitishness is distributed in these tissues. So this basically explains to you that there could be presence of some abnormals in these particular lungs, and so you can prepare in advance and try to explore further to know what exactly these problems could be. So there's techniques of how to prepare our clients for chest X-ray, and the first thing pre-chest X-ray is you're supposed to guide our patient that they should remove all the jewelries or metal objects so that they don't interfere with the X-ray films when you're checking on their chest. And then the chest X-ray should be taken upright, that is, if the patient status permits. But if in cases where the patient is not able to stand, there are maneuvers that can be done to help a patient be in a upright sit-up position to allow exploration of the chest. And before the procedure, tell the patient to take a deep breath, hold that breath, remain still as the chest X-ray is being taken. And then they can now produce the different diagrams that come out after doing this procedure. So this is the procedure here. Stand upright, take a deep breath, hold it, then the X-rays will be passed through and a film will be produced in regards to the structures that have been explored. So how do we interpret all these images? So when it comes to the interpretation, it will depend with the film that you have accessed, but there are basic things that you need to counter check, before you make a final diagnosis. So in this case, check the correct patient name, correct date of birth, look at the symmetry of the two sides, the chest, that is the lungs, are they equal in size? Are they well distributed? Are they in their proper positions and all that? Look at the shape, look at the bony structures of the chest wall. Remember, the X-ray will produce for you the bony alignment of the ribs, the vertebra, sometimes you're able to also see it, and the clavicle, best if you're checking it from the back, sideways, or front. Then look at the mediastinal contours, that is the mediastinum. How is it positioned? Are you able to see the alignment of the heart? Look at the hilum, look at the size of the lungs, position of the diaphragm, is it properly positioned? Check any soft tissues, and that is like the lung walls, the soft tissues. Do they have any infiltrate that you can tell could be affecting the appearance and all that? The heart size, is it enlarged? Is it within its normal demarcations? All these are important. Areas behind the heart, costophrenic angles, like these are very key parts that you want to evaluate on the chest X-ray. For instance, here we have a normal supine radiography of a thorax, or basically, of the chest. And we are looking at the different areas where we're being told this bone, that is the clavicle is supine, meaning it's at the back, so it's not on the front side, but on the front you can see there the ribs, that is the rib alignment, that is now like that is now like frontal to the lungs, and we have our lung tissues here. So all this black film is basically indicating to you our normal lung tissues. And then in the white area here, we got our heart, which is deviating to the left. And the diaphragmic areas is down here, which you can check it. So this is a normal chest X-ray for the thorax. If there were abnormalities, then we'll be able to see the whitish intensifying and spreading out in the different parts of these tissues to see where the areas are affected are. Then the second types of image technique is the computated tomography scan, or what we also call CT scan. So this is an imaging method that we also use, and we do this in successive layers. We also use X-ray beams, but the main thing is we first introduce the radiographic contrast media before we go in with the X-ray. The radiographic contrast mainly is to help us identify where the main areas are, or the main problems are. So we could either use iodine, okay, or other iodine is like the commonest radiographic contrast media that we used, or any other. So most of the time we are asked to let the patient know or ask from the patient if they have any allergies to these radioactive contrast medias. And so for this, most of the time you give it to the patient, and then it will accumulate in the area where the problem is. For instance, if you have cancer, then the patient will be, you will be introduced to iodine, that is IV system. And then through the IV system, the iodine will go, and it has high affinity to the cancerous cells. So it will be absorbed by these cancer cells in the areas where the cancer is located. And then when you do the CT scan, it will show the demarcations of the cancer very clearly. So for example, in the chest X-ray, we are able to identify some abnormal, structure somewhere around our tracheal areas and the aortas. But with the chest X-ray, you are not able to get these details clearly. You're not able to clearly determine how the cancer is, how far is it, how big is it, and all that. But CT scan, you can successively explore this cancer tissue, how much it has been, it has spread out, the size, the appearance, and if it's pushing on the structures around it, and so on. So you can see in this CT scan here, it can show the tumors clearly. So the main issue with CT scan, you basically need to confirm if your patient has allergies or if your patient is reactive to the radiographic contrast medias. And then the other famous one is magnetic resonance imaging, commonly known as MRI. So we're told the advantage with MRI is that, radiation is avoided, that is. And what happened is with resonance imaging, most of the time it's like we are using sound waves. So it's indicated for visualization of great vessels and the heart. So we use it more in suspected tumor inversions of the mediastinums and the chest walls. So it also helps us to check the structures, but the main thing that it does is there are no radiation rays here. We don't do X-ray kind of approach. but what we use is the sound waves to help us identify the structures and how they're affected, the change in size, and so on. Mostly this is for soft tissues. We do it a lot for soft tissues, like the great vessels, the heart, and any other needed soft tissues around either the mediastinum or the chest walls. So with pulse oximetry, this is a procedure done that is helping us to determine the estimation of arterial oxyhemoglobin saturation using a wavelength of light. And because of this, how we happen or how we do it, we normally pass a light beam through a vascular bed. In this vascular bed, we can use either the finger, we can use the earlobe, determine the amount of light absorbed by the oxygenated or the deoxygenated blood. So this is how we use it. So this is our oximetry machine or the oximeter, and you get to use either the fingers. For children is when now you can go for the earlobe, because sometimes the fingers are so small they may not fit on this machine properly. And it will calculate for us the amount of arterial blood that is saturated with oxygen, and it will display itself as SA2 or SA02. This is to show the value of oxygen or the saturation of oxygen, and it will display itself as a digital value. So here is a fingertip that has been fixed well, and then we have the SpO2s coming out. So this SpO2 is simply showing for us the saturation of oxygen in our blood system. Normally, we are told with a good saturation, you can record at least 95% and above. And the machine, the beauty of it, it will also record for us the pulse. So it normally gives us the pulse rate here, and it can also give you the SpO2. So it will give you two values at the same time. So it's a good machine for different reasons. You can use it to monitor oxygen saturations for clients maybe who are on oxygen management, or clients who are on home oxygen therapy, and so on. So common indication for pulse oximetry is number one, to monitor the adequacy of oxygen saturation, especially for clients who are on oxygen therapy and you want to see how they're responding. We also use it to monitor unstable clients who may experience sudden changes in blood oxygen levels. Very common when you look at it from ICU or intensive care units, where there's a client who needs constant checkups and monitoring of their oxygen values. And then we have ovulation for need for home therapy, that is home oxygen therapy. If you have a client, let's say from intensive care units, and you're looking at discharge for home, you can evaluate if you might need to take with them for oxygen management while they're still at home. You can also use SpO2s or pulse oximetry to determine any need for supplemental oxygen needs where a client is at rest, doing exercises, or during sleep. So these are all different indicators that you can use to evaluate the need for pulse oximetry in our patients. But the main thing is pulse oximetry is a machine or a tool that we use to give us the level of oxygen saturation in our blood system. So you fix it on a fingertip or on a finger, or you can fix it on an earlobe for children if you want to determine the level of oxygenation. Sputum examination, this is an additional that I've added up. So what sputum examination does, sputum may be obtained for different reasons. That's one thing that we need to understand first. But once we have the sputum specimen, we are normally advised that with the sputum specimen, you check the appearance. So that is the consistency of the sputum, how the appearance of the sputum is, that is in terms of color. Is it green? Is it yellow? Is it plain? Then there's the quantity, how much of the sputum has been produced, and the odor. Is the odor like smelling false smells, or there's no smell? Then there's formation. How does it look like? How is it appearing? And all those stuffs. Then there's microscopic examination of the sputum, like you can send it for example, like microscopic exam under microscope, generally to observe it under microscopic state, but you can also take it for culture and sensitivity to identify the microorganisms that have been growing in this partum. Could be bacteria, viruses, or even the fungi and parasites. So you want to explore all this under a microscope, but you can also culture it if you want to be more accurate. So sputum exam simply means you collect the mucus or the sputum that has been produced by clients, most of clients who have cough that is accompanied by mucus or mucus secretions. And so you're able to evaluate all this. And so that marks the end of our first class on non-invasive procedures that can be done for respiratory illnesses. And if this content really is awesome, kindly you can like, share, and subscribe. Give us a comment and a review if this has been helpful to you. So thank you so much and see you in our next lessons.